تفضل.
He's mute.
أسعد الله مساءكم وأهلا بكم جميعا في محاضرة هذا المساء، وهي بعنوان سايكومتري. يقدمها الدكتور هيثم الجهرمي من مملكة البحرين، وهو باحث في العلوم النفسية. تفضل دكتور هيثم.
هو ميوت دكتور وليد.
مم. تفضل.
مساء الخير جميعا. بروف، I noticed you unmuted me. تحب أبدأ؟
لا لا، تفضل.
You may start دكتور هيثم.
عفوا، ظهر الصوت بالخطأ، صار ميوت. شكرا جزيلا بروف على الاستضافة مرة أخرى، وشكرا على هذه المبادرة حقيقة اللي قاعدة تخلينا نتعلم كلنا من بعض. وإن شاء الله اليوم عرض، ما راح يكون عرض حقيقة قد ما راح يكون إن شاء الله فرصة للنقاش، وفرصة حقيقة لمشاركة التجارب يعني. ولا المجموعة مليئة بأساتذتي وكبار العلماء اللي صراحة نفتخر فيهم. ف I will start to share my screen. آه، بين فترة والثانية كنت ألاحظ على المجموعة إن في طلبات حق بعض الاستبانات، أو طلبات حق بعض الأدوات اللي ممكن تستخدم لقياس سواء كان الاكتئاب، اكتئاب ما بعد الولادة. وكانوا الجماعة في كثير من الأوقات يصيرون شوية بانيكي لما يكتشفون إن ما في نسخة معربة، وكانوا شوية يصيرون أكثر بانيكي لما يعرفون إن النسخة المعربة ما تم معايرتها أو توثيق مصداقيتها ومعايرتها. فقلت إن شاء الله هذه يعني يمكن اليوم تكون فرصة إن أنا أشارك بالشيء البسيط اللي تعلمته من خلال السنوات اللي مضت، طبعا من خلال العمل الكلينيكي، بس أكثر يمكن من خلال العمل البحثي أو من خلال النشر، لأن هي من متطلبات النشر والتوثيق حقيقة. ف... فإن شاء الله راح أشارك على مجموعة روابط من خلال الفترة اللي اشتغلت عليها. اكتشفت انهم من افضل الروابط اللي ممكن الواحد يستفيد منهم للحصول على استبيانات. طبعا هذا احد المواقع، وهذا يمكن اكثر واحد انا رشحه، ومدعوم حقيقة ببعض تقنيات الذكاء الاصطناعي. يعني مثلا إذا كتبنا ديبريشن راح يعطيني كل السكيلز اللي لهم علاقة بالدبريشن، وراح يعطيني وصلات التحميل وأيضا وصلات التراجم في حال إذا كانت وجدت أي نوع من التراجم. وطبعا هذه الخدمة مجانية وما تتطلب أي اشتراك، يعني لوج إن أند داونلود مثل ما يقولوا. إن شاء الله صوتي واضح.
واضح، نعم.
كلش كلش.
وشكرا جزيلا بروف. والموقع الثاني طبعا سيكولوجي تولز، اكيد مر على كثيرين. في نسخة مدفوعة وفي نسخة مجانية. طبعا انا ارشح النسخة المجانية باعتبارها ان هي كافية، والواحد ممكن انه يعمل اكثر من اكاونت في حال انه احتاج. هذه النسخة توفر خدمة السابقة ما تعطيها، اللي هي كليرنس فور كوبي رايت. يعني مثلا اذا واحد حاب يعمل ترجمة او يعمل فاليديشن هو كان بنفسه، ممكن ياخذ هذه الخدمة من هذا الموقع بشكل مباشر. الرويال كولleges باختلاف انواعهم عادة يحطون recommendation during residency during fellowships for the recommended clinical skills خلال فترة تدريبهم. وأنا حطيت مثال على الكلية البريطانية. في موقعين آخرين إن شاء الله راح أنا أشاركهم، بحيث أن تكون إن شاء الله حصيلة مجمعة لكل الأخوة والأخوات، بحيث أن يستفيدون منها في أعمالهم الكلينيكية وأيضا في أعمالهم إن شاء الله البحثية، لهم ولطلابهم وللأجيال اللي قاعدين يدربونها. فاليوم احنا راح نتكلم عن شغلة شوية يمكن تكون إلى حد معين مزعجة لأنها إحصائية. It's pure mathematics، يعني احنا نتكلم عن علم السايكومتريكس أو علم القياس، ولكن إن شاء الله we will try to make it as light as possible، بحيث we don't feel the heat مثل ما يقولوا. ف why psychometrics is important and why in psychiatry specifically. Uh, Two reasons actually. The first reason is that most of our diagnosis, most of our follow-ups, most of our patient care is dependent on the history that we take. So our diagnosis, our care, our follow-up is only as good as how good information we are collecting. If we are collecting the correct information, we are having a right path for the treatment. If we are computing or if we are collecting low quality information، معناتها ان احنا we are ending with a dead end مثل ما يقولوا. Is very important here for me to determine two things. بعض الأحيان people actually confuse them، وسامحوني أنا قاعد أستخدم اللغتين بس إن شاء الله يعني تكون يعني بعد أحسن new style. The thing between scales and the questionnaires. دائما when I hear the word scale يجي في مخي جلاسكو كوما scale. ف immediately I think it's a physician administered, it's a clinician administered. I don't ask the patient open your eye, open your mouth, raise your hand, move your head, talk to me, or I evaluate him. لا. I ask the patient, I have a normal conversation, I do some basic muscle power testing, and I can say this patient is a 3 or this patient is 15. A questionnaire is when I give patients a piece of paper. Oh, now it's now becoming all digitalized, nobody use papers, and I ask people to self-report. Correlation or reliability or consistency, if you like, between scales and questionnaires over the years and over more than 17 systematic reviews and meta-analyses has been proven to be at best 85%. So we have 15% lag between the quality of information delivered by patient and the quality of information that is sought or obtained by the physicians. So I'm not going to talk about the statistical information here, and this is actually very basic. Or it will be time to waste حقيقة. بس when we talk about validation, I want to highlight one thing. Historically, when we used to validate tests, like a psychometric test for clinical use, we were looking for two important parameters, at best sometimes four. We were looking for reliability, we were looking for validity, and we looking for goodness. Basically, we are talking about sensitivity and specificity. But now, as the world is moving, and as statistical science is actually moving, there is a new models or a new approaches to validation. These are known as item response theory. Item response theory, it gives us two additional information plus the reliability and the validity and the sensitivity and specificity. It's very important to recognize that item response theory is not used in solo. It should be always used to complement the classical testing theory. Item response theory, it gives us information about how easy are items, how common it is to make mistakes in items, and the final element is how can we merge two items to obtain a third piece of information. When we talk about reliability, now we will talk about a little bit of math numbers, and I will share with you some of my experience and some of my observation. وفي نفس الوقت I will be more than happy to assist any research team or any clinical team to translate and validate any test they have. When it's come to statistical competence, we have a very good active team in Arabia that we work regularly on improving the banks of Arabic translated clinical scales. When we talk about reliability, we have to address three parameters when we talk about the reliability. I will start with the first one, which is the internal consistency. This is the mostly common or mostly known as alpha, كرومباخ alpha. كلنا سمعنا عنها، كلنا قريناها في papers، كلنا سمعنا عنها when we review articles. I would like to tell you something, that two things are being mispracticed. Number one, people think the higher the alpha, the better it is. This was actually an old piece of information. Yes, alpha كل ما يرتفع يكون أفضل. But once it reach 0.90, it starts to lose its significance. Actually, if alpha is more than 0.95, it means that internal consistency is very high. And internal consistency is very high, معناته we are asking a lot of questions that are giving us the same answer. I will suggest two things here. Whenever we are reporting papers, رقم واحد, as we report clinical or we report our own Cronbach alpha, regardless if the test has been validated or not validated in Arabic. This is my first take-home message. The second thing is a Cronbach alpha between 0.07 and 0.09 is considered as good. Less than this, more than this is considered as questionable. Test-retest reliability is when we are repeating the test to see if it is not subject to memory bias, if it's not subject to an environmental change, if it's not subject to any type of confounding factors. We want to see the reliability over time. Here, the same similar mathematical equations is being used, but it is mostly in the form of ICC or intra-class correlation coefficient. I should say here coefficients for the second C. Target should be between 0.07 and 0.90. test retest reliability can actually go to 0.95 and 0.98 even. And this is not giving us the same problem of internal consistency. Actually, if the test retest reliability is more than 95, it shows that this test is stable over time. It doesn't show it is getting more reliable over time. It is more of a stable score over time. Or the change in score in the population is homogeneous, if you like. When the test is being administered by more than one group, خلينا ناخذ a clinical example, مثلا Connors test. Connors, we know that we have children, we have adult, we have parents, we have a school, we have the teacher. So if we want to measure how these different people are giving us a reliable information about the same patient or about the same piece of information, the inter-rater reliability will be our target. Here we can use equations like Cohen's or Flesch-Kaba, but we can also use similar to what we used in test-retest reliability, which is the internal, the intra-class coefficient. Target here should be also between 70 to 90, 95%. The second thing is when we are trying to do some testing, we are looking for the concept of validity. Reliability, I was trying to learn some of the Arabic terminology, but to make sure when we are also publishing in Arabic, we are familiar also with this terminology. Reliability, which we spoke about earlier, it's known as thabat. And validity, it is صدق, or how much it is stable to capture the original idea that I want to capture. I don't put questions related to personality disorder if I want to obtain history about a case with depression. Yes, I ask about personality. We have to take proper history, but if we have established clinical leads, we should focus on the clinical problem at hand. Validity is about matching the problem with the actual scenario that we face. Here, we have three types of validity, and I will tell you a brief story about each one so we know when to use them. But I will tell you something else before I go to do this. Why did I put reliability before validity? Most people will say validity and reliability. But if you consider the guideline of international medical questionnaires, which is known as COSMIN, they will tell you reliability and validity, because reliability is actually a prerequisite for validity. You cannot have something that is valid if it's not been established to be first reliable. Should be first reliable, and then you can establish the validity. In reporting, in clinical work, this doesn't matter so much. But in terms of scientific flow of idea, I'm only clarifying this. So for validity, we have the content validity. And this is just to make sure that the idea that we are collecting is actually matched with the idea that we are intended to do. So if I developed a questionnaire, if I translated a questionnaire, I should take it to experts, people like Prof. وليد Sirhan, Prof. like Nizar, like Prof. Ahmed. They read the questionnaire, they read the item, and they tell me if these items actually matching with the problem that I'm trying to measure. This is a very easy type of validity. When we are translating questionnaires, there is a procedure to ensure this, is that two people should translate it from English or whatever language, Chinese, Mandarin, whatever other language we are bringing it to, into Arabic. And two people should do a back translation. This is considered as forward and back translation to ensure content validity. We then have something called a criterion validity. And this is actually very important for sensitivity and specificity. Sensitivity and specificity, I'm sorry. We know that we have a lot of questionnaires, a lot of tools to measure depression. Most of people in this room, most of the people who's listening to this or people who will listen to this later, they are familiar with the JAD-7 or the PHQ-9 to measure symptoms of depression. We all use them from time to time. They are good, easy, fast to use, but can they replace a psychiatrist? Here, where we are talking about sensitivity and specificity, their accuracy rate. I'm not going to dig in each of this because this is not our topic today. Generally, we are trying to obtain a global score of 70 or more percent. Again, the higher score, the better score. Rarely you will surpass 95%. And this should be always matched with the gold standard. Why do I say the gold standard? Because this is actually an opportunity for me to make a very good point for non-psychiatrists or for people even from general medical background. When I take history from patient and I compare it to the scale of PHQ-9, I'm comparing it against gold standard because the gold standard here for diagnosis is taking history. And the good test for screening is PHQ-9. But if I am trying to assess something medical, something from internal medicine, let's say GERD, something very common, gastric acid reflux, the gold standard will not be history taking. The gold standard will be against endoscope or against the result of imaging, barium testing, for example, or pH testing. So gold standard is dependent on the field, is dependent on the norm, the conventions of that branch of medicine that we would like to examine. The last concept of validity that we would like to try to measure, and this is actually very important for scientific publication, is we try to report something called factor structure. And this is for the construct validity, to make sure that all of the questions that we asked, all of the 9 questions that we asked in PHQ-9 are related to the concept of depression. ما يكون the first question, which is about the mood, is very highly correlated with the score of 70 or 80, but the score for anhedonia is very little, like 0.1 or 0.2. All items should be more than 0.5 or more to be considered as a factorially structured questionnaire. The previous 2 steps, which is reliability and validity, can be applied to all of the scenarios, whether we are translating, whether we are using our own questionnaires, our own developed questionnaires. Because if we establish their psychometrics, we are implying that these questionnaires or these scales or these measures can be reused again. They are producing something that is called as reproducibility. So we talked about some of these concepts already, and we gave a lot of examples. You will have a lot of time to measure this. It's very important to recognize that in most cases, we were advised that we should not combine different questionnaires or different tools, and we should use them in solo. I think I can speak this from a practice. No, we can actually merge 2 or 3 different questionnaires, and this is now becoming a trend in psychosomatic medicine, particularly. Maybe not with psychotic patients when we are talking about PANS, but when we are talking about depressive disorders and sleep problems and somatization disorders, we can actually do this blend. And there has been a lot of examples that I can share later. We can adapt some of the existing tools for developed for adults or children, like ADHD, the Adult Standardized Reporting Scale. We can modify it to match our culture, and particularly for teens. This is known as cross-cultural validation. Now we get the bigger problem is when we take a scale and we take our results, usually we should examine our normative scores. One of the most commonly scales that I use in my sleep clinic is the Pittsburgh Sleep Quality Index. PSQI, or Pittsburgh Sleep Quality Index, suggests that anyone above the point of 5 out of 21 is considered as a poor sleeper. The Chinese actually noticed this observation much far beyond us, and they have determined that the cutoff of 5 is not suitable because the sleep practices between East and West is actually different. For example, we have naps, we have fasting, we have morning prayers, we have noises, we have a lot of things that can, we live in big houses, big crowded houses, different type of family structure. So they have increased the score to 7. Now in my clinic, we use 3 cutoff points. We use actually 5, we use 7, but we use also 9 to determine patients that we should refer to polysomnography clinic for further screening, particularly if we suspect disordered breathing. So different cutoff points can set for different threshold, can serve for different purposes. And these cutoff points were not set arbitrary. These were set based on previous studies, but these were set also based on our normative scores. As I told you, most of our patients score more than 5. So setting it as 5 will be completely useless. Setting it at 7, similar to the Chinese experience, is very good. But setting it to 9 will help us to filter those who should go for a further examination. Why we should try to investigate and implement more? I think I want to highlight 3 things here. The first thing is that when we are training young residents, or when we are training people from the primary healthcare, we should train them for screening, not for diagnosis. And they can refer cases that they suspect complication. So the first thing, these clinical scales can help with making decisions. About the workflow, because I want to link it here with the electronic health record or the electronic medical record. Last week, when we talked about electronic stuff, AI jumped very quickly. And now we cannot have any conversation with anybody without bringing AI to the equation. During COVID-19, Google itself actually launched a project to collect the score about people's anxiety. And they were offering to do JAD7s, which is anxiety screening for people, and giving them suggestions about when they should speak with a psychologist or a psychiatrist, when they should practice self-care, and when it's the time to do further actions beyond just visiting an outpatient clinic, because there were cases of high severity, and we all witnessed this. Now, with AI actually increasing, it's very important to recognize that the questionnaires in the next 5 years will not be actually questionnaires. There will be no opportunity for patients to attend the clinic and we give them a piece of paper to fill a report. Even highly graded clinical questionnaires or clinical scales, sorry, not questionnaires. We say the questionnaires are self-report, like the MMPI, which is used for personality profiling. My reading, speculations from expert groups, is that everything will be replaced by apps and everything will be connected with the electronic health record. So basically, we will be able to detect specific parameters even before the patient actually come to visit us. The United Arab Emirates have a very nice experience for child psychiatry. Actually, upon their referral, parents are giving a website whereby they fill a couple of questionnaires. So when they arrive for screening or when they arrive for formal autistic algorithm, the child psychiatrist will already have sufficient information about child and will know how to tamper or direct the dialogue. And last but not least, how to implement it. We face with our population a big problem, which is a stigma. People don't like to speak, but people will be much easier reporting it to a computer. I get surprised by many of patients who come to me, especially females in Bahrain. They will not be fully happy to be exposing part of their hands for observation if they are, or examination if they have a rash, but they will be very willingly to take a lot of pictures and share it on Chat GPT. So this paradox need to be equalized. We need to do validation and revalidation. Arabic is a very beautiful language, but Arabic dialect is one of the hardest languages. So it's no harm of developing a Tunisian version, a Bahraini or a GCC version, a Jordanian or اللهجة الشامية بحيث انها تكون cover a whole cluster than a single country. I want just to conclude, to wrap it up, to make opportunity or room for discussion, is employing these questionnaires is not coming free of charge. Some are for fees, and we should be very observant prior using them, whether it's for research or for clinical purposes. There has been several cases of lawsuits, particularly for publication, and there has been numerous of papers that has been retracted that I'm familiar with because of infringement of copyright. But when I said no cost, we should also monitor patient privacy, because once the information on paper or on app or somewhere on another media, people can access it and we don't know who is accessing it or how it will be accessed. And electronic environment, the virtual environment, is very fragile. Nobody can guarantee how secure it is, despite to how much security measures we have. When we use these questionnaires or these clinical guidelines to take history, it's very important that symptoms overlap and comorbidity exist. So sometimes symptoms that can explained by, let's say, OCD or some sort of anxieties can be triggered actually because of psychosis. So we need to be very cautious about how can we use them, when to use them, and how do we implement them. I think by this time, if you allow me to stop and we can have a discussion, because I think talking about this all day like this will not be any good for anybody, and maybe I can help to shed some light when we are discussing things together.
شكرا جزيلا دكتور هيثم على هذا العرض المفيد والذي نحتاجه دائما. ويعني في نقطة بأنه فيه مصطلحات مثلا بيك انفنتوري، يعني سكيل ولا هي كويشنير. أحيانا بالسيرفيز بيعملوا يعني سيلف ريتنج سيرفي، برضو التسميات هاي لا زالت مختلطة. يعني هل هناك مرجعية لتحديد التسميات؟ هل كلمة سيلف ريتنج لازم تحدد نوع المقياس، أم أن هناك يعني قاعدة أخرى؟
نعم بروف. there is the Cosmin guidelines حقيقة يتناول كل هذه التصانيف ويعطي تصنيفهم بشكل باينري. if
مهم.
it's يعني المخ، مثل ما هاي حقيقة تعلمتها منك، المخ من زمان تعلمتها منك، المخ يحب الأشياء الباينري، الأشياء
مهم.
السهلة، أبيض
مهم.
أو أسود، yes or
مهم.
no. ف if it's more of a self report, it's a questionnaire, it's a survey,
مهم.
it's a self report. If it's collected by a physician or a trained personnel, يعني MMPI, an IQ, other personality measures, they cannot be done over the internet. حتى لو عند الأوراق، حتى لو he obtained basic material, he cannot complete the actual test. He cannot complete the actual scoring. He cannot complete the actual normalization and interpretation. So this is where it's become more of a scale.
نعم. دكتور نزار تفضل.
شكرا دكتور وليد، بالطبع بالاستمرار على هذه المحاضرات الجيدة. وشكرا دكتور هيثم for dissecting a very complicated subject. I like the way that you clarified it for us. Everything is nice and clear. I've got two questions. The first one is about the translation and the back translation. And this, my question applies to psychiatry, to general medicine, and to other fields also, like, for example, chemistry or even sociology or whatever. The persons who are doing the translation, which one is more valid and more dependable? A person who is a clinician and with knowledge in language, or the other way around, somebody who is a linguist, expert in language, and has some knowledge in clinical matters? Or is there a third option? What do you prefer?
Yes, thank you, Prof. Amin, for this, Prof. Nizar, for this important question. Here I can talk from actually limited experience. I will not say a very huge experience, but I did a lot of experimentation around the translation. The best thing that I observed, and it actually matched with the guidelines of Cosmin, is that professionals do the translation. So two psychiatrists, two psychologists, a psychiatrist and a psychologist, they do the forward translation. Then they get matched by a certain team member. They amalgamate them, they put them in one version, and they give them to another two people who are blinded. These two people should be also professionals from the same discipline preferred. They do the back translation. Once they complete, because we are not linguistic experts, here where for syntax tightening, we need the linguistic to make sure male, female, to make sure الحركات, القواعد, matching it with modern Arabic language. And then we can do a pilot testing. Before we roll it out for general population, it should be pilot tested. And pilot testing should be targeting lay men and women from all of the general population. So it's a bit of everything.
Okay, excellent. Thank you very much.
دكتور أمين.
مساء الخير وشكرا جزيلا دكتور هيثم على المحاضرة القيمة. الحقيقة أنا إنسان كلينيشن، يعني مضيت سنين وأنا أعمل في الكلينيكال ورك، ولكن لا شك الريسيرش والسايكومتريك تيستينج كانت part of our work. يعني there are some challenges and difficulties we faced through the years. Very often I find extremely difficult to accept the psychometric testing in philosophical related to major depressive disorders or schizophrenia. But it's easy, more easy to accept it in, as Dr. Nizar mentioned, about biochemistry. For example, the relation between depression and eating disorders. It's very valid. But when I talk about PTSD, for example, I find it difficult. The reality is that the limitation in the psychometric testing can make the decision about the management plan and the care plan extremely difficult. I find it, I need to go back to the patient. The test in itself, it doesn't really give me adequate information about what is the best to do for the patient. Definitely, as you said, there are some limitations. I understand that. But also at the same time, I feel that we are, you mentioned about AI, we are running too much toward this kind of westernization of mental health or psychiatry without accepting the fact that we need to address these issues slowly, gradually, to find out if they are suitable to our community and our culture. Thank you very much.
Thank you, Prof. Amin.
هي سؤال آخر من الحضور؟
السلام عليكم.
عليكم السلام ورحمة الله.
يعني شكرا على المحاضرة القيمة. عندي يعني ملاحظتين. يعني في الوقت الحاضر اللي كثرة عفوا الصوت تمام. في الوقت الحاضر يعني نلاحظ أن يعني أكو عزوف عن ملء الاستبيانات الإلكترونية، يعني ما أعرف بسبب كثرته، فكيف يعني ممكن نقنع الناس في أن يعني يملأ الكويشنير؟ هاي النقطة. النقطة الثانية، كيف نضمن أنه هذا الكويشنير يعني مع هاي الثورة في ال AI ما ممكن أن تملأ من قبل ال AI؟ شكرا جزيلا.
ايه نعم، والله سؤالين مثل ما يقولوا challenges. I will try to answer them to my best. When you try to fill any electronic thing, there is, and I face this actually a lot when we do research, particularly when we do it with young people, with students. They try to outsmart. So they try to collect large number of people and they seek machines that are filling questionnaires. They call actually stealth participants. These are very easy to detect because when you fill any electronic form online, for validation to make sure that it's a human, it's not AI, you have to solve usually a small puzzle. So you can add this, but this will actually add more question and make it more boring for people. The second thing, I spoke about IRT or item response theory, and I didn't talk about it a lot. Item response theory will show you actually if there is a straight pattern. There is no chance that there will be 7 or 8 people that will tell you it's a score of a 3 out of 5 for all of the questions. Only a machine will do this, or a very 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 hard luck. يعني واحد من الاثنين. شبه معجزة أو a machine is filling this. So doing this, now with all of the questionnaires, there is also something called a timestamp. So time in, time out. If the time is less than the logical time to complete the questions, then it is an AI, it is not a human. I would like to make comment actually also about Dr. Amin comment. This art of psychometrics is not going to become very ledger for us anymore. I think it will be mandatory, particularly if we are going to move toward pharma. I completely agree with him. Nothing will replace a human psychiatrist. Nothing will replace a human expert. But having objective measures, this is the problem that we face in psychiatry. We have difficulty to put ratings. But if we have objective measures to measure subjectivity, which is symptoms, then it is becoming easier to convince the world about efficacy, effectiveness, or improvement of treatments. All of the guidelines that is being developed, let's say the most difficult problem in psychiatry, schizophrenia, in my suggestion, there is no treatment that will be approved if they fail to show specific scores of PANS, which is the positive and negative symptom score, which is again is the scale that we are familiar with to measure the psychotic different domains. So it's not black or white, it's a mix of everything. Thank you.
أي سؤال آخر من الحضور؟ لم يكن هناك أسئلة فلن نطيل عليكم. شكرا دكتور هيثم على هذه المشاركة القيمة، وأنا متأكد أن الجميع قد استفاد منها، والتسجيل سيكون على اليوتيوب لمن فاته الحضور. دمتم بخير وإلى اللقاء.
تصبحون على خير. شكرا بروف على هالمبادرة مرة أخرى.